Welcome everyone, and thank you for joining today's webinar, Primary Care Provider Burnout, What States Need to Know and What They Can Do About It. I'm Jennifer Reck, a Project Director here at the National Academy for State Health Policy, or NASHP as we are known. I will be moderating today's webinar. This webinar is offered with support from Virginia Commonwealth University as part of its work with the Heart of Virginia Healthcare Collaborative, one of 7 regional collaboratives participating in the Agency for Healthcare Research and Quality's Evidence Now initiative that reaches 1,500 practices nationwide to improve cardiovascular disease prevention. Before we get started, I'd like to clarify a few logistical items. First, you should be able to hear the webinar through your computer speakers, or you can call the number listed on the screen. The lines will be muted for the duration of the webinar to eliminate background noise. At any point, however, you can ask a question by typing it into the chat box located at the bottom left of your screen. We'll be responding to questions both through the chat box and during the Q&A portion of the webinar, which will follow our last speaker's remarks. A recording of the webinar will be available on the National Academy for State Health Policy website at nashb.org within the next few days. And finally, one important thing I wanted to point out is that there are no speaker slides today by design. So please don't be concerned that there's a technical difficulty if you are not seeing slides advance during the speaker's remarks. And now I'll give you a quick overview of the ground that we will cover today. First, we'll hear from Dr. Tony Chisel, Principal Investigator for the Heart of Virginia Healthcare Collaborative. Dr. Chisel will provide an overview of the scope, causes, and impact of provider burnout, as well as some strategies for addressing it. Next, we'll get an on-the-ground look into primary care provider burnout from Mike Talley, a practice coach with experience encountering and addressing burnout in practices participating in the Heart of Virginia Healthcare's work. He'll be joined in conversation by Kathy Kelly, a family nurse practitioner at a participating practice. Finally, we will be joined by Bill Hazel, Secretary of Health and Human Resources for the Commonwealth of Virginia. Secretary Hazel will serve as a discussant, providing reactions to the presentations, as well as reflections on their broader health policy implications from his joint perspective as both a physician and state official. After Secretary Hazel's remarks, we'll have some time saved for any questions for the speakers. So I think that's a great lineup that we have for this afternoon. Many thanks to all our speakers today and to all of those joining in to listen. And first, it's my pleasure to introduce Dr. Tony Chisel, Principal Investigator for the Heart of Virginia Healthcare Cooperative, on behalf of Virginia Commonwealth University School of Medicine, where he has served on the faculty since 1984. He is currently the Harris Mayo Distinguished Professor and Chair for the Department of Family Medicine and Population Health. He earned his medical degree from the University of Illinois and completed his residency training in family medicine at McNeil Memorial Hospital in suburban Chicago. He also has a master's in health professions education with research interests including practice performance measurement and management and facilitating and measuring the impact of practice redesign. And with that, Dr. Chisel, I'll turn things over to you, please.
Well, thank you very much, Jennifer, and thanks to NASHB for organizing and hosting this webinar. My thanks to our other presenters that you'll be hearing, and to all of you who are joining us on the webinar. We will endeavor to give you important and useful information and suggest action steps that might be considered at the state level. As Jennifer mentioned, we are one of 7 collaboratives that were funded by the Agency for Healthcare Research and Quality, and the emphasis is on improving attention to cardiovascular risk factor identification and reduction. Our premise when we put this grant in is that we saw increasing signs of stress in primary care practices, and we believe that it would be difficult to field an effective quality improvement strategy if we didn't first address those things. We designed a program in which all the practices that were engaged would have three ways of being supported. One is to participate in a kickoff meeting in which we would bring forth some of the most important ideas and strategies that we thought would help practices and perhaps afford them a little bit of inspiration and a kickstart to engaging with us. That's followed by a coaching phase, and you'll hear more about that from our next speakers, in which practice coaches are linking with clinicians and staff at the participating practices and figuring out how can they make things easier, better for all concerned, including importantly for patients, and therefore create the foundation for moving the needle on these important quality measures. And then finally, there's ongoing support for a period of 9 months in which practices have access to our coaches and our physician faculty. So I'd like to just elaborate a little bit more on why we were concerned about increasing rates of burnout among clinicians. It's not just based on our impressions from what we're seeing in the Commonwealth of Virginia and aware of it elsewhere, but national surveys have shown, and I think the NASHB newsletter published in January spoke to this directly, that in 2011, 45% of family physicians reported one or more symptoms of burnout. That had increased to 55% in 2014. And satisfaction with work-life balance went from 48% in 2011 down to 41% in 2014. The major contributing factors that folks have studied and kind of uncovered are EMRs, probably number one. They have powers that paper charts systems don't have, but we're finding that it takes a lot more time documenting EMRs than it did in paper charts. And that clinicians are actually therefore spending less face-to-face time with patients. Bureaucratic burdens, a myriad of reporting requirements, an avalanche of forms, and clinicians may spend as much time with documenting and fulfilling bureaucratic requirements as they do caring for patients. There have been some published time motion studies that would suggest that that's actually true, that it's now as bad as a 50-50 split in terms of hours spent in the day. A lot of clinicians feel a loss of autonomy. They are trading that in for a sense of security by joining large networks. The landscape of healthcare reform or re-reform is so uncertain for both players large and small that it is naturally attractive to think that if I'm part of a bigger network, maybe I'll be protected from some of these things. But often that does mean that you're not the only person who makes decisions about what's happening in your office. And going along with that, for a variety of reasons, there's increasing productivity pressures on clinicians. So what's the impact of burnout? It's been associated, when studied, with lower patient satisfaction scores and lower care quality. There are higher medical error rates, and that, of course, increases malpractice risk as well as the risk to patients. Higher physician and staff turnover, increasing risks for physician alcohol and drug abuse and addiction, and increasing risk for, I should say clinician, not just physician, increasing risk for clinician suicide. Now, when we looked at the rates of burnout from the Heart of Virginia healthcare practices, and we have about 220 practices, small to medium primary care practices that care for adults across the Commonwealth, we measured that a bit differently than the national survey I reported on earlier, for reasons I don't need to get into, but it appears that the rate of burnout among physicians and nurse practitioners in our study is slightly less than the national figure, perhaps 5 to 7% less, but it's still quite significant. What we believe could be strategies to reduce burnout and return joy to practice, and ones that we are advocating as part of our Heart of Virginia Healthcare initiative, is around first practice redesign, and some simple moves include things like moving work that is commonly happening between office visits now in primary care practices and get that work back into office visits. You know, the vast majority of clinicians in primary care are paid fee-for-service. You're not paid for the time and effort you're putting in between office visits, so it makes sense to try to get it back, move back in, and that would include things like strategies so that you can review labs face-to-face with your patient, and renewing and managing chronic medications in a synchronous fashion in the context of an office visit. This actually reduces staff time that's currently spent on these other activities that's happening in between visits. And you can use the staff time that's freed up to do things that you weren't able to do before, like pre-visit planning, which helps you to have a more systematic attention to not only cardiovascular risk factor reduction, but that can be expanded to other things like diabetes or preventive service delivery. You want to employ all staff to the top of their license and ability to jointly address all the tasks, including the bureaucratic burdens that aren't going to go away with a snap of the finger, and employ strategies to reduce the burden of documentation in the EMR. In my own practice, we've chosen to use scribes to do that. It's been a game changer for us. Not all practices want to do that or are able to do that, but there are kind of team documentation models that some offices can employ that can at least spread that work around a little bit. And I think it's also important at a personal level for everyone in the practice to think about how can they improve their work-life balance. I was reading about some of the things that are advocated by folks who are working hard on this, and it's pretty simple, but it's important to do, that you put time for yourself and your family on your calendar as the first thing you think about when you're thinking about your next week or your next month, and you stick to it. One other strategy for people who have a significant other as part of their life is to have intentional date nights and stick to that as well. And what some have called a big bucket list and a weekly bucket list. So you think about what are the things that would really energize me and sort of recharge my personal batteries and my spiritual batteries, and what I imagine that would be in terms of big deal things that I might do once every year or two. But importantly, what would I do each week that would help to put that energy in? So I'll stop there and invite our coach and clinician team that follow to talk about what their experience has been.
Thank you, Dr. Chisel. Yes, and that's a perfect lead-in to hear from our next speakers. We'll be hearing from Mike Talley, a physician practice consultant for Health Quality Innovators. Mike has served as a practice coach to practices participating in the Heart of Virginia Healthcare, working to improve cardiovascular disease prevention, including practice redesign strategies to help address and alleviate burnout. And Mike will be joined in conversation by Kathy Kelly. Kathy has been a family nurse practitioner for 7 years and works at Charles City Regional Health Services, a nonprofit community health center with federally qualified health center status. Charles City is one of the practices participating in the Heart of Virginia Healthcare Cooperative, and Kathy has taken an active role in the initiatives there. We appreciate her taking time out of her busy clinical schedule to join us today in conversation with Mike. So Mike and Kathy, the floor is yours.
Thank you.
Thank you. Again, my name is Michael, and I am one of the practice physicians coaches under physician services here at HQI. We have many other team members that are doing the same type of work, and I just want to put that out there that we appreciate their work too, and I'm happy to be selected to facilitate with Kathy. I've known Kathy over the past several months for our Cohort 3 for Heart of Virginia Healthcare Initiative, and she is a very busy nurse practitioner at a very rural facility, and she serves a various population of patients that have many different needs. Kathy's facility is also part of a larger corporate group, as was stated, and we have about 17 facilities that we are visiting and assisting the physicians in some of the areas such as burnout. And so Kathy, thank you today for your time and insight. And when we first came to your practice, could you tell us just previously, prior to me meeting you, what were some of the barriers or friction points or that touched on burnout that existed for you prior to engaging with Heart of Virginia Healthcare?
Sure, Mike, I'd be happy to. It was interesting because the week that you came was really a catalyst week for us as a site, particularly our OA, Kim Jones, and myself. Communication was a big issue at our office. We had a lot of workflow issues. We had a lot of not accountability, taking responsibility, a lot of issues with just the in and out of the day, and like was mentioned earlier, between labs and follow-up and computer work, not having a really great workflow of delegation. And communication, it always came back to communication for us between the front desk and the back. We also have dental and behavioral health in our office, interactions between nurses, interactions between staff and nurses, and it always came back for us, I think, the commonality was a lack of communication. And we were able to address a lot of things the week that you came in. Some of it we had started on our own, and by you coming in, it really validated that we were on the right track, and then you were able to give us so many amazing pointers that we were able to take and run with.
And speaking on our initial engagement, I remember seeing you coming down the hall of your facility, and you were kind of pondering or mulling over, here's this guy here, and maybe it's another initiative, and I'll kind of, salute the flag and do my part. You had kind of that look on your face, but after we went to your office and talked a while after that initial engagement, what tools can you give to our audience that you selected? Because every practice is different. What tools did you employ at that present time that helped you deal with some of the burnout issues?
Well, the 3 days before you came in, we had already initiated going back to huddles. Huddles was something that we had done prior, and we had tried various ways, and we talked to you about it when you came in. And one of the suggestions you made was for accountability was to make it visual, whether it be a whiteboard or a sticky, something that made it official that you could write and cross off as you did. Up to that point, our huddles were initially verbal, and again, it was who said what and how did that get translated, and what one person heard was different than what someone else heard. Then we tried doing notes, and again, it was a great thought. We put a lot of times, Kim Jones, our OA, spent a lot of time taking detailed notes and passing them out, only to find them, under piles. So one of the suggestions you had with the whiteboard was excellent. So we initiated the day that you mentioned it, and our huddles are now done on a continuous board. We put up the things that are the most important to us. We assign tasks to people, and it's only crossed off when it's been completed, and then we move forward. What that did for us, it took the finger pointing away. When it was verbal and when it was on paper notes, it didn't happen. But when it was there and every day we're saying, okay, so where are we at on X, Y, or Z, we were holding staff accountable. The other thing is we were able to put up positives. It wasn't always things that we needed to work on. It was also shout-outs. And again, Kim was excellent at giving shout-outs to staff and to providers. And we included our front desk as much as possible. So we were able to look at our patients that were coming in for the day, get a plan on what we needed to do for them. We were all hearing it up front. So that was helpful. Another issue that we had that was very frustrating was no-show rates. We would set our whole day and then look at the schedule, and there would be gaps, or there would be multiple no-shows or reschedules. So one of the things that we started doing was simply walking our patients up for customer service. So before the patient walks out the room, I give the nurse when I need them to come back. And for customer service, they walk them up to their front desk, ask the front desk if there's anything else they need from the patient, and inform them that they'll be coming back in 3 months or 6 months for their follow-up visit. What that did for us was cut down on phone calls that were inundating the front desk that weren't necessary, or our schedule would double book because the patient thought they were here for lab only and they were really for an appointment, or vice versa. And it has tremendously reduced our no-show rate. Another thing we've done is have our providers, since we have behavioral health, dental all together, we now meet once a month as providers outside of staff. And we can come up with things how we can better support one another and support our patients and support our staff. And a good example was we had a near code situation in our office yesterday, and we were able to, again, Kim Jones was able to get our Dr. Stone, our behavioral health psychologist, to come over and sit with the family because we had that communication where we know how to alert her when we need an emergency. So that was very helpful. Medication refills, another thing that we addressed with patients. Referrals, how we handle those, we've addressed. How we delegate our workflow and what we're empowering the nurses to do to work to their highest level of their licensure. We've addressed that as well, which has taken a lot off my plate, which allows me to do more of what I need to do. So all of it together is us working as a team. And our communication is, it's not perfect, but it is 75 to 80% better than it was before.
That is great, and I think you mentioned something that's very important and is a good pivot point for us at this point for our audience. Dealing with patients, pre- and post-visits. Patients come in, a lot of the burnout is with doctors or physicians are taking on more and more responsibility, especially in rural areas where there's not a lot of specialty practices that are closer by. So the general physician practitioner has a lot of weight on their shoulders when they deal with a patient with multiple issues. So I know we worked on some pre- and post-visit tools with some of your staff members. Is there anything that you are utilizing as a tool to prevent a lot of the patients coming in and not being prepared for their visits that was adding to burnout?
Well, we've made signs to remind patients so that we can better care for them to bring their medications, because we spend a lot of time trying to figure out medications that we write or multiple providers write. So that was one helpful thing. When they call for their appointment, we remind them of that also. We are starting to work on follow-up phone calls. So after a sick visit, we're trying to now, in the next week or so, now that we've got a lot of other things under our belt, following up with patients. And we're looking at doing a pre-registration for new patients where we can call them, get all their information into the system, as well as nursing doing their medication. And we're looking at welcome packets as well for our new patients that kind of go over our policies, how to reach us after hours, what you need to be bringing to your office visit to be prepared to make the office visit go smoothly. Also working on goals for patients. What do you expect out of your appointment today? Sometimes they'll come with 10 or 15 things. We have to pick the top 2 things that we're going to go over. And then, again, by walking them out, okay, Kathy needs to see you back next week about this, and then in 3 months for this. We've also worked on adding pre-labs to our chronic visits. So now when we're walking them up, we're giving them a choice. Do you want to do your labs on the same day of your visit, or would you like to get your lab results when you come? And I'll put the order in for a few days before their office visit. We're finding with that the folks who are retired or not working are open to that. Folks who are working prefer to do everything at one visit. So we're getting about 50-50, but we are seeing a difference.
Wonderful, wonderful. And now I'll kind of tie everything together and we'll concentrate on you a little bit. I know you had shared some things about the power of being a physician and getting some of that power back, some of the things that you had let kind of filter to others, and then you would have to go back and retouch on some of those things. So I found that very interesting that you had made that statement to me as an individual physician, because I was able to utilize that in some of the other rural facilities. So tell the audience a little bit about, as an individual physician, how burnout had changed you and how you got back to having joy in practicing.
Well, nurse practitioner, not physician. But
Thank you.
Nope, that's okay. I clarified all day long. So for me, I think, well, it's more of a personal type thing. This practice always had 2 providers, and for a long time we haven't had that. And that was a huge responsibility to shoulder. And initially it was taken on very excitedly of all the things we wanted to change and do at the office that we'd always wanted to do, and very eager, and spent a lot of effort and time doing those changes. And then we've had 3 providers come and go, well 4 actually, in 2 years. And each one decided to pick apart what we had initiated, Kim and myself. So eventually you kind of felt like, I'm just going to go see my patients, do my job, and leave on my time. And so the week that you came, something not so nice happened at our office, and it really shook myself and Kim Jones to the point that we had to sit and say, this is not okay. And there was a literal decision made. It happened on a Friday, the situation. On a Monday, I found out about it, and so did Kim. Monday night, I went home and really contemplated, would I go back on Tuesday? Tuesday morning, I woke up and said, no, my mistake was giving my power away to people who are no longer here. I am taking back what is mine. And until somebody removes me from this office, this is how I'm doing things that I see are appropriate by my corporate policy, by my licensing policies, by my ethical policies, but this is how we're going to do it, and we're all going to get on board, or some of us won't be here. And sure enough, a few people aren't here anymore because we realized that they didn't want to participate. They didn't want to do the things that we were looking to do. Everything we tried to do, there was this sabotage mentality. But I tell you what, Mike, that accountability with the huddles made it really clear where those issues were. And those folks moved on to other places, and we have an amazing staff who do care about our patients, who are excited, who throw out ideas now, who want to be involved in making it better. And there are days where we don't do as well as we want to do, and there are days where we knock it out of the park. But I can say that we're working really hard together as a team, and I think by Kim and I saying this is the standard and this is where we're going to do and this is how we're going to excel, this is what we expect, I think people rise to that level, and that's what was lacking before.
Well, thank you for sharing that, and I think that touches on the heart of Virginia healthcare right there, and that quadruple aim of restoring joy in the practice is sometimes change is hard, and if we're given the correct tools and we utilize those tools in the correct manner, we will see positive change. And these are best practice solutions that we gather not only from other initiatives and expert faculty such as Dr. Chisel and team leads, but also other practice coaches, other practices and other initiatives and collaboratives. And so thank you for sharing that. I think that gets to the heart of the matter as an individual, some of the things that you experience in a very rural area. And that'll bring me to a pivot point so that we can dry the tears here. But that'll bring me to another point. One of the things I wanted to discuss as part of the burnout was the paperwork and the ever-changing technology and reporting requirements for physicians and clinicians. One of the things that I tried to do was to be as non-invasive with my CDHS practices at the physician level, and went to the corporate level to fix as much as we could with the vendor and the EHRs as we could before making that contact and adding to the physician's plate those stressors that, well, now I have to, start looking at this and that. So we pulled baseline measures for our ABCS measures. We looked at them as a team and gave some feedback to the corporate and fixed those little things that the EHR was not capturing or excluding before we brought the data to the physician level so that you could have a more accurate picture. And I think, Kathy, you were smiling when I shared your numbers with you because your numbers were at an excellent level. So how did you feel about that approach, not just coming to you and sort of giving you a bunch of numbers and saying, we got to improve this?
No, it was a great approach, and I imagine that as hard as we've been working at UDS, our numbers are going to blow you away in about 3 months. And again, it's a team effort. Us delegating a lot of things that providers were holding on to. I made an algorithm the other day, as a matter of fact, now that I think about it, because we have colonoscopies and PAPs and mammas that we're working on. And we were having the nurses contact patients to see if they had it, get the report, and update the UDS. What was happening was a lot of patients were saying, no, I haven't had it, but I do want to. Can you put in a referral? So I sat down and really quickly wrote out an algorithm of if they have no insurance, this is what we do. If they have this insurance, this is what we do. And if they have this, this is what we did. And I did it for PAP, mammo, and colonoscopy. I did one, showed it to the nurses. I had them do one and show me that they could do it, and then I let them go. And they've done an amazing job, and when our numbers go up, it's going to be because of April Woods, our amazing LPN. Before, I don't think we would have done that. We would have held those cards close to us. We would have tried to control it, and the only thing we did was make an algorithm and make sure that they could see one, do one, teach one, and it worked. And they're doing amazing. So I would say that method filtered not just to us, but we used it as a teaching point of how we could also share those responsibilities with other patients to help reduce, with other staff members to help improve our numbers. And again, it was delegation and not holding those cards so tight in those reins.
And thank you for touching on scope of practice, because I think that's a very important tool to assist physicians is utilizing their staff, including their front desk people, to the top of their credentialing. Because I noticed that when I did the workflows, I always would start with the front desk and work my way back as a patient would see it when they came for a visit. And one of the most interesting things that I found was all of your staff had an eclectic background of educational pursuits, and everybody had different strengths. And one person had a degree in chemistry, and another person was working on a degree in veterinarian assistant. And I said, but yet here you are in medicine, and how can Kathy utilize you and Kim, your office manager, utilize you to the top of the scope of your practice? And you all incorporating those decision trees. These are the types of messages I will never be able to take. These are the types of messages I can take. These are the types of messages that should go to the nurse, the MA, or to the physician. How has that helped you reduce your burnout? So at the end of the day, when you're finished seeing your patients, now it's time to check those messages.
It's helped a lot because instead of every message coming to me, which is what it was, literally, every piece of paper comes to me because I'm the only provider here full-time. So every hospital note, every lab, every medication refill, every consult report for every patient in this office comes to my desk, every lab, everything. So when you added phone calls, and I was basically doing triage and would just end up taking the phone and doing it myself, it has helped tremendously. So it starts with the front desk, absolutely, and they're doing an amazing job. And then the fact that we have three amazing nurses. And again, like you said, we play to the strengths. That's something that we're working on now as we're having people in different roles each day to kind of figure out who's doing what. We might as well put our strongest lab person at drawing the labs instead of the person who isn't as strong as that person. But that person is amazing at patient education, and we need them with our diabetics and our hypertensive patient. And the person who will not let a med get past them, that needs to be my check-in person. And so we are really working to people's strengths and letting them know, you are amazing at this. That's why we're tasking you with this. And people and they feel pride in what they're doing, and they want to do well because they know that we think they're amazing at what they do already.
Well, I think our time is coming to a close, and I just want to say, ending on that note, you're amazing, Kathy. You are amazing. It's been a pleasure working with you. And
it's a pleasure to work with you too, Mike.
And on behalf of HQI, I would like to turn it back over to you, Jennifer, and thank you again for this opportunity.
Okay. Thank you so much, Mike and Kathy. And finally, we're pleased to be joined today by Dr. William Hazel, Secretary of Health and Human Services for the Commonwealth of Virginia. Prior to becoming Secretary in 2010, Dr. Hazel practiced orthopedic surgery in Northern Virginia and was a founding member of Commonwealth Orthopedics and Rehabilitation, where he gained extensive experience working in our healthcare system while helping to lead a large group practice. Dr. Hazel has served as a trustee of the American Medical Association and as speaker and president of the Medical Society of Virginia. He earned his medical degree at Duke University School of Medicine in 1983 and completed his orthopedic surgery residency at the Mayo Clinic in 1988 before returning home to Virginia. And because we are still less than a week out from the Super Bowl, I should mention that he also at one time served as assistant orthopedic for the Washington Redskins. And as Secretary, Dr. Hazel oversees 11 state agencies, including such diverse programs as Medicaid, behavioral health, social services, as well as aging and rehabilitation. And during his first term as Secretary, he led the Virginia Health Reform Initiative, helped establish the Virginia Center for Health Innovation, and served as the founding chair of Connect Virginia, Virginia's Health Information Exchange. So thank you so much for joining us today, Secretary Hazel. I will now give the floor to you to please share your thoughts and reactions to today's presentation.
Thank you, Jennifer. I guess it's good that everybody's on mute, or otherwise when you said the Washington football team name, they might have all booed, but who knows. I had the pleasure of practicing orthopedics for 22 years before I became secretary, and I've been in recovery from the practice of orthopedic surgery now for about 7 years, or actually just a little over that. And I can assure you that there are better cures for burnout out there than becoming secretary. And I say that somewhat facetiously, but the stress and the burdens of practice do tend to add up over time. And so I think it is, as an individual, I think these types of things are really, really important. I appreciate Tony Chisel's work, the VCU work of putting this program together. I had not had the opportunity to meet Michael and Kathy before hearing their voices today. I hope no one needed an interpreter for Michael, but I'm sure you could understand him well. And Kathy, your story is just sometimes getting fed up is so compelling. I think the reason that I, as secretary, support this, and I think why we as state officials have to care about this, is there are very few things I think that are as important to the individuals in our states as having a health system. And absent providers that are fully invested and operating really at the top of their game, it's going to be very hard for us to have the health system that we want. So we need to think through how we cultivate the workforce and how we be sure that the jobs are actually doable. And this is a particular issue in areas of concern to us in the Commonwealth, such as addiction treatment, behavioral health issues, and so forth, where there are general inordinate complexities involved in treating people. If you've ever read Stephen Covey's work, he talks about the difference between your sphere of interest and your sphere of influence. And if you just take a moment and draw a big circle on a paper and then put a small circle in it, the big circle is your sphere of interest or your sphere of concerns, all the things that you worry about. And the smaller circle is the sphere of influence, the things that you can actually control. And I think I, as a physician, become frustrated, and I see it in others when there's so many things out there that you really hope to influence, but you really can't do anything about. And in certain areas of practice, for instance, an individual who has a substance use issue, whether it's alcohol, opiates, whatever, if you don't know how you can help that individual, it's going to be a source of frustration. I noticed that's one thing that I would add It's not scientific, it's not in the literature, but I think a major contributing factor for a lot of physicians not wanting to participate in some of the public programs is that the individuals that they're seeing may not be able to take advantage of the therapies and the treatments that are offered. So we really do need to think through those things as well. The state, the government has several levers to try to improve the environment for practice. And one is just in our capacity as purchasers, how we use our Medicaid purchasing power, how we use our health insurance plan for the state employees can impact this, particularly as we look at payment models and requirements around electronic medical records, et cetera. It gives us some ability to demand what we want paid for and how we want it to be purchased. Another lever is regulatory. What will the boards, nursing and health professional, medicine, and so forth do in terms of regulations related to practice and expectations? We can see legislative levers. Our General Assembly's in right now, and we are looking at issues related to emergency room diversion and so forth, the ability to ensure that individuals get back to their primary care physicians in a timely fashion, or perhaps even avoid unnecessary emergency room visits. These are all things that we have at Access. And then there's the bully pulpit, which sometimes works and unfortunately sometimes doesn't work because you need to have someone listening. So we can look at specific issues. Scope of practice is one. Clearly most states are having discussions around who can do what. And we tend to talk about practicing at the top of your license, or top of your certification, but I think it's really the top of your abilities is also important if you're going to have job satisfaction. Another piece is workforce training. Are we ensuring that we have an adequate number of people in the workforce and that the expectations when they come out are appropriate? Can people with lots of debt do primary care, and will there be stresses related to income and loans and so forth, and even comparison with friends who did not take the numbers of years to go through the training to practice? We have reporting requirements at the state level, obviously, but one of the things that we can look at and can work with plans on, particularly through our Medicaid and state health plan levers, are some of the reporting requirements. It is just impossible to work for 5 different health plans that have 5 different sets of quality indicators for a particular problem, such as managing diabetes. It just makes no sense. And I think that we can use the power of the government, the authority of government, or the convening power to help in that area. Another area that we are looking at in Virginia is this whole issue of electronic health records. One of the items I know that has come out of the effort here in Virginia is the recognition that when efforts are made to demonstrate quality of practice, you can't get the information you need out of your health IT system. And there are 100 and some systems being used in Virginia right now, and they typically were built off of billing systems and weren't designed to do quality reporting. And I think that we have some ability, using federal monies and so forth, to help encourage the purchase of systems that are appropriate and will help us get the information we need to be successful and to compete, really, in a value-based payment world. So there are a number of areas where I think that we have a role in government that can help, provided that we can get some consensus from the provider community about what they need. One of the challenges we run into is there's so many ideas and everyone has their own, that it's hard to winnow them down to the key elements that we can actually act on in a policy framework. I think that the issues ahead of us, at least for the short term, will not be easier, simply because we are in the transition to a value-based payment world. And Dr. Chisel mentioned that the challenge in some ways of having fee-for-service and the need to look at labs in the context of a visit in order to get paid. When CMS is successful through the macro legislation and converting us more to a value-based world, will that still be the case? So how will we make the change back at that time? And I think it's going to take quite some time, I think, for the change and the pressure to settle out. So I suspect that a big piece of this will be teaching the practices to continue to learn and adapt as they go forward. So with that, Jennifer, I am happy to take questions, and I know you've got some questions for the others as well.
Okay, thank you very much, Secretary Hazel. So yes, that concludes our presentations for today, and we do have some time left for questions and answers. And we'll give our listening audience just a few minutes to please enter any questions that you might have into the chat box at the lower left of your computer screen. And while we're waiting for participants to join in with some questions, I will kick things off with a line of questions for Dr. Chisel, please. I know we here at NASHB have heard accounts from states that some are encountering increasing difficulties recruiting practices to participate in various quality pilots or demonstrations or reform demonstrations. And I'm wondering if you can speak somewhat broadly about any advice you might have for states that are trying to successfully recruit primary care practices, and if you can let us know a little bit more about your own experiences recruiting for the Heart of Virginia Healthcare, please.
Sure. I think all the things that Secretary Hazel spoke to in terms of making things a little easier for the primary care clinicians in the state are critical. You had some additional suggestions I read in your newsletter, the NASHB newsletter that you published in January. So there's that. I think that just having a recognition that this is an issue and then figuring out who can we partner with, we in state government, who can we partner with in our state that we can work on this together so we can get better information about what's going on, why it might be going on, and what could we do about it. The other, I think, is to recognize that I think in a lot of states, the primary care physicians are increasingly part of systems and the days of predominance of independent practices I think are probably over for good. So you have to be mindful of the health systems in your state that employ, or if not employ, at least have an aggregation in an IPA sort of a model of primary care clinicians, and be speaking to the leadership of those organizations about what could we be doing together to address this problem.
Thank you. And Secretary Hazel, can I run that question by you as well? If you have any specific thoughts about effective approaches to recruiting primary care practices for state demonstrations?
I was not involved in the direct recruiting, but I know that it was difficult at times, and I think the big thing was a lot of folks just say, I don't need one more thing. One more thing is the straw that breaks my back. And getting beyond that point of frustration, and perhaps Michael's point where you sit down and you find something that makes it easier for people right from the start and get a few quick wins, or offer something that's quick and relatively easy and painless, it will help get people interested. I think the idea that you're going to commit 9 months of self-evaluation after you are already frustrated is, I think you have to have something that is much more appealing than that. And so the fact that you could come in and lighten the load immediately is probably helpful.
Thank you. We're getting just a few questions here and in the chat box, if you'll bear with me for a second. And here's a question that perhaps is more directed to providers and inspiring them. When will the providers band together to try to have the amount of documentation time reduced so they can increase quality time with patients? The additional 5 hours a day added on to document, that's where burnout is occurring. So I think that's definitely a very pertinent comment touching on some of the documentation requirements or burdensome documentation requirements that we've touched on.
Right. This is Tony Chisel. I'm aware that being a family physician, I kind of pay attention to what the American Academy of Family Physicians is doing about a variety of things, and this is one area that they have a focus on, and been imploring CMS to be open to the notion that the documentation and coding guidelines that are presently in place are really not enhancing patient care, are not making care better for patients, and are adding to the burden that clinicians have. And if you look at the notes that get generated from templates, which are just an attempt to please, I don't want to spend most of my life in the EMR, you lose what's the story here really, and what's really going on. So I think that's not going to happen. It's something that states can do, although I would say that if states together think this is important, they could think of how can we support these kinds of efforts. So I think thinking how can we make documentation in the medical record really for the care of patients again, as opposed to driven by regulatory requirements and billing requirements. That would be a huge win. But in the meantime, while we're working that problem, I still do think that a variety of team documentation strategies can work. And I haven't called it out yet, and I'd like to do that now. We are using in our Heart of Virginia Healthcare curriculum, if you will, something that the AMA put together. Chris Sinsky, one of the innovators on how practices can do things less painfully, has something called Steps Forward. If you go to www.stepsforward.org, you'll see a variety of strategies aimed at making life easier for offices and their staff and better for patients. So I see what we're advocating now as kind of a way of reducing the pain and suffering that is a consequence of some of the things that are in place now, while are working at a national level to take away some of those things.
Jennifer, Bill Hazel, if I could jump in on this, these documentation things go back to the billing requirements from the 1990s. And my biggest hope is that as part of the macro legislation that enables paying for value, we'll stop paying for documenting bullet points. And I think as you look at the coding and the requirements for documentation simply to get paid were absurd. And it is my sincere hope that as we go through this reform process, physician nurse voices will be added to the chorus that says the craziness has to stop.
Okay, thank you. Shifting to the conversation that we had about scope of practice issues, there is a question that says there's new legislation this session, and it's referring to SB 1327, and I can't tell from the question, but I'm guessing that might be Virginia-based legislation. And this legislation deals with a new degree and licensure for physician assistants called a Doctor of Medical Science. I'm curious about the reactions from the panel concerning this type of concept. Is that something that any of our panelists are familiar with or could speak to?
This is Bill Hazel. There is a school in Southwest Virginia, actually on the line with Tennessee, that has a physician's assistant program that has put forth this as one potential way to solve our workforce shortage issue. It has come up, and I have not seen anything happen to that bill at this point. I would say that it was a one-off, and clearly has not been universally accepted at this in terms of from either the physician or I believe even from the physician assistant community.
Okay, thank you. And we have this next contribution is more of a comment than a question that I think it's interesting and worthwhile to put on the table for our speakers. It would seem that connecting any statewide efforts to the CMS MACRA Quality Payment Program efforts, as well as the triple aim, would be ideal. Aligning resources and efforts across programs and showing that the value from any given program moves the practice in the right direction, in the right direction in this developing payment world. Physicians need to see the connection between improvements in clinical processes, improvements in patient care, improvements in joy in practice. MACRA, PCMH, joy in practice, etc., can all be mutually supportive rather than separately or at odds with one another. I think that
Tony, again, I completely agree.
Yeah, this is Bill. I would agree with that. I think one of the things we have to think about through the MACRA reform now is that in some states like ours, the primary vehicle at the state level has been using Medicaid rules to promote change. A challenge that we'll have to be wary of going forward is that it is not unusual for the Medicare folks in Washington and Baltimore to have a little different of opinion of things than the Medicaid people, and we need to be very clear that those are completely aligned going forward.
All right. A very true and worthwhile point. And with that, I will do a final call for any last-minute questions. We have just about a minute left here. Seeing none, I'm going to go ahead and close our webinar today. Thank you again to all of our speakers and to everyone that joined today's webinar. Dr. Chisel referred a number of times to the NASHB January newsletter, in which we published a brief entitled Primary Care Provider Burnout, Implications for States and Strategies for Mitigation. And you can access that brief at the NASHB website if you're interested in follow-up or more information about today's webinar topic. We will post the recording of this webinar on the NASHB website in the next couple of days. And we ask you to please fill out the very short survey that will appear at the conclusion of this webinar in your browser window. And once again, thank you to all for joining today for a very interesting discussion. Bye.
Thank you. Bye-bye.
Thank you.